Assalamu alaikum. So my name is Dr. Qurrath, and my today's topic, what I'll be dealing is internal anatomy variation of permanent teeth. So these are my contents for today's topic. So coming to the introduction, as general practitioners, it's very important that we understand the internal anatomical variations, whether it is a deciduous tooth or the permanent tooth. It's very important. The reason why, because there are various changes which occurs because the root canal is very complex. So it's very important to understand the number of canals, the number of roots, so that it becomes much easier for a clinician to go about the debridement, as well as the chemomechanical preparation, as well the three-dimensional obturation. So this is my topic. Why is it important? So I would be talking in the beginning, the general methods, how you can identify this extra canals. So before going into that, there are two terminologies I would like to tell. One is called as the major apical foramen. The second thing is called as the minor constriction. Now, what is this major apical foramen? It is the exit of the root canal surface to the exterior surface of your root surface. So normally it varies from 0 to 3 millimeters, and the minor constriction is this. So normally we say that the minor constriction is the apical portion of the root canal system which has a very narrow diameter. So as you can see in this picture, the diameter normally varies from 0.5 to 1 millimeter. Now, why is it important? Because this is the area at which your instrumentation or your obturation should exactly end here. So that's why this is important. So if you see in this picture, you can see a space. There is a space which is present between this minor constriction and the major constriction. And this space is normally called as funnel shaped. It is funnel shaped, or it is also called as hyperbolic, or it is also called as monogloring appearance. So that's why I put a picture for this. So now coming to how to identify these canals. So clinically, any patient who comes to your clinic, and when you start, when you go ahead with the root canal procedure, it's very important. The first thing to locate the canals is to see the dimension of the crowns. So normally what happens whenever you expect for an extra canal or extra root, generally the dimension of your crown will be slightly bigger when compared to that of your normal. Or if you see the cingulum area, there can be presence of tubercle. And one of the most classic feature is the developmental grooves. Now these developmental grooves are normally present onto the, say the labial aspect or the buccal aspect of your crown, of your root, as well as the lingual or the palatal aspect of your root. Now, as a clinician, whenever any patient who comes to you for the root canal treatment, definitely there is a deep dental caries. So what happens when you excavate the decay, there'll be loss of tooth structure varying from 30 to 50%. So now what happens, how can you evaluate the crown now, the dimension of the crown? In such scenarios, what you need to do is you need to check for the contralateral tooth so that, you can identify again the dimension of your crown. Now, I said that there should be presence of deep grooves which are present on your root surface. So if there is any frank recession, what you can do is you can take a probe, run towards the cervical aspect and slightly down till wherever there is a recession, both on the buccal as well as the palatal aspect. If you probe that area, if you feel that there is any fusion line, then you can think that yes, there can be an extra root or a canal. Now that's how you go about in the clinical examination. When you go ahead with the preoperative, definitely with the radiographs, but you know that the radiograph is a two-dimensional view of a three-dimensional object. So it does not give you a clear picture, exact clear picture. It's very difficult to get from a radiograph. So if you go into a literature, there are n number of literatures which states that it's very important apart from a straight angulation technique. So normally we go ahead with the paralleling technique. It's very important that you have another two radiographs with mesial and distal angulation. So this is at the most important in diagnosis, radiographic diagnosis of extra canals. This is very important. Now, this is a picture. If you see here, you can see a huge radio density starting from the canal orifice till the coronal aspect of the root. But if you see towards the middle third, there is this line is diminished or slightly it's very faint. So this could be this could actually tell, this radiograph could actually tell that yes, there can be a presence of extra canal. If you see the first radiograph, you can see there is a frank bifurcation here. If you see that this area is a radiolucent, but towards the middle third, I can see a faint line here and here. So there could be a bifurcation or trifurcation. So again, the radiographs are very important. Now I had put this picture to basically to tell that if you see in this picture, the obturation looks quite fine for me. But still, there is a presence of periapical lesion towards the lateral aspect. And there is also a presence of faint line here. So now it's very important that if there is a presence of a lateral lesion, it can show that they can be lateral canals, your apical deltas, or they can be extra canal. This is very important. Or if you have a X-ray depicting two different periapical radiolucencies. So when there is two different periapical radiolucency, again, this will show that they are extra roots or extra canals. So this is how you go ahead with the preoperative method. But apart from this, it's very, very important that you have to go ahead with certain, equipments. You should have certain armamentarium like loops or microscope, nothing better than that. It becomes more easier for you to understand the internal anatomic variations. It becomes more easier. So what you can do is, if you have a loop basically varying from 2.5 to 3.5x, it's the best tool. And also, if you see in literature, they say that the CBCT, it's like a boon in endodontics. So this can be used as a pre-operative assessment, okay, to know the complex anatomy. As well, along with that, when you use a microscope or a loop, there is immense success rate in the root canal therapy. So this is like a boon in the field of endodontics. Now coming to the intraoperative identification. Now, most of the times when we do a access cavity preparation, especially for your upper and lower anteriors, it's utmost important to remove the lingual shelf. I'll show you in the next pictures that the lingual aspect of the dentine needs to be removed. When this is not removed, you're surely going to miss the canals, because if you see the lower anteriors, around 40 to 45% of the cases have two canals. So the reason why a clinician misses this extra canal is because the lingual shoulder is not been removed. So this is again very important. And also, when you place a file, now say you have got a canal in your lower anterior. So you place the file, but you feel that the file is not centrally placed. You feel that a slight deviation, in the placement of the file. So basically it is eccentric. Then you can think, yes, there can be an extra canal. Now you place a file, you feel that the file is going exactly towards the center. Now you take a mesial or a distal angulation. When you take a X-ray, and in that you can make out that, it's not going exactly till your root tip. Again, there is a slight deviation of your file from the root tip. Now you again radiographically can think, yes, there could be an extra canal. Again, if there is any bleeding which occurs, eccentric bleeding. Now, if you feel that in an upper central incisor towards the center, normally you get your canal, for example. Now, if you feel that there is a bleeding occurring more incisally, so that could be an extra canal. So again, clinically, you can evaluate with certain things like this. Now, post-operative assessment. Now, it's very important that I'll just show this X-ray, you'll understand better. So in this, if you see the, the canal looks, for me properly, it looks very normal. I don't feel that there is any very obvious change in the anatomy here. But after the obturation is done, you can feel that some irregularity is here. This is nothing but your sealer which has been extruded, to your second canal. So again, now for example, say this is a buccal canal you have obturated. Now, how to know that whether it is a lingual canal? What you need to do is, you need to pre-curve the file and place it in such a manner that it is touching the lingual aspect of your dentine, your root dentine. Okay, and then take a different angulation X-ray, and then you can confirm it, like how this clinician has done here. So coming to the endodontic management. So what happens whenever you go ahead with a radiograph, say a mesial or a distal angulation radiograph, it, sometimes you feel that, the master cone or the files are overlapping, you're not very sure whether it is 2 canal or 1 canal. You're not able to, exactly see clearly. So then what you can do is you can use, definitely you have to use an electronics apex locator. So the electronic apex locator will try to, dissolve your confusion, whether there are 2 canals or 1 canal. So this is a very important tool in endodontics. And before you start any biomechanical preparation, now when you feel that there are 2 canals, 2 roots, it's very important that you need to understand the internal canal anatomy, especially in the apical third, because there'll be sharp curvatures, okay? So this needs to be taken into mind. It's not only about the extra root or the extra canals. They can be even acute 90-degree curvatures at your apical third. That definitely needs to be considered before even starting or introducing your any rotary file inside the root canal system. This is very important. And also, before starting any biomechanical preparation, I feel as a clinician, it's very important to understand the cross section of your tooth. When I say cross section, for example, your mandibular anteriors, they are wide buccolingually, but they are very narrow mesiodistally. So when you try to do a overzealous preparation mesiodistally, it's gonna fail. You're gonna do a strip perforation, or after say 1 year or 2 years, the tooth is gonna fracture. Your root is gonna fracture, definitely. So it is not about how your obturation is gonna look post-operatively. It's very important that you understand certain things before you even start the instrumentation, so that you do not, in spite of doing a good job, you do not, cause a failure. So this is very important. Now, talking about the internal anatomical variations in anteriors. So the incidence for your anteriors for extra canals is around 0.5 to 3%. The most common type of variation seen is what you see is type 2 and type 4. So I would be telling you what are the various classification of what you see in my further slides. So this is certain case reports in which they have said, like they can be 2 roots, 2 canals, they can be 1 root, 4 canals, they can be 1 root, 3 canals. So there is a lot of literature in your upper anteriors with enormous canals and roots. So now this is how your upper anterior central incisor would look like when you do an axis cavity preparation. So what happens is, this is your main canal, and the second canal is exactly present equidistant. If you see in the first picture. If you see in the second picture, this is your main canal, whereas the second canal is present slightly distal to your main canal. And if you also see, this canal looks slightly huge when compared to your second canal. Now, I said type 2 is the most common vertices classification seen. So it basically means that there are 2 different canals, okay, which starts from the canal orifice, and one goes till the root tip, whereas the second meets the first canal in the apical third and then ends into 1. So we basically say that this is 2, 1, this is 2, 2, 1. So this is what we say. And again, this is the second picture which depicts, if you see here, this is the resorption which has happened. So whenever there is a resorption, there is a change of the vertices from type 2 to type 4. So this has 2 different canal orifices which are ending into 2 different apical foramina. So this is called as type 4 vertice. So this is a clinical picture which depicts the axis cavity preparation. If you see here, there are 2 canals which are present equidistant to each other. But if you see here, there is a huge canal, whereas the second canal is slightly at an angulation and it is smaller. So this is the clinical representation. Now, this case, I would like to share it because I wanted to tell you what are the difficulties I faced in this case. So this was a case which was attempted by my fellow dentist, and said that I'm not able to negotiate the canal. And I was like, okay, so it's going to be very challenging. When I saw this X-ray, I felt that there is a resorption because I could find a huge lesion here. So I thought this could be an internal resorption. Okay, I thought, okay, might be it's an internal resorption, and I started this case. I felt, let me start with 8 size K file. Okay, seeing the, canal, which looked very narrow for me. So I started with 8 size K file. I was not able to go. The file was bending. Again, the file was bending. I was not at all able to go. Then again, I tried. What I did is, it's very important once the axis is opened that you have to flush sodium hypochlorite onto your pulpal floor. This is very important. And apply some amount of EDTA towards onto your file and then start negotiating. So then I thought, okay, let me try once again. Then I negotiated. And then I could feel that the first file which was introduced was this in this canal. And then I felt this is not going towards the apex. I thought, have I perforated or have I zipped the canal or something like that? Then I thought might be there is extra canal because I felt that the lesion is exactly here. So definitely there should be one canal here. Then again, I started negotiating here and I got two canals. This was one of the most difficult cases I had done. The reason why being because the two canals were very close to each other. It was like the main canal, the file is going easily. The second canal, it was very difficult. It's like once I place the file and then I remove it, again I try to place, I have to place some 4-5 times and only then the, the file goes inside the canal. So in such kind of cases, it is very important to achieve glide path. So what you can do is, you can use a 6 size K file. I started with 6 size K file and I made sure it is super loose inside the canal. Only then I introduced a 8 size K file. Again, that being super loose inside the canal. And then I started the recapitulation with 6. Then I used the 10 size K file. Then again, that should be super loose inside the canal. Again, I recapitulated with 6, 8, 10. And only then I introduced the rotary file inside. What happens is the diameter of such extra canals are very narrow. So when you try to, directly introduce any rotary file without doing, without achieving adequate glide path, believe me, the file is going to separate inside the canal. And that again will become more challenging. So this is very important. And one tip for your obturation is that in such kind of cases, when the canals are very close to each other, you cannot place both the master cones together. So what happens is one master cone will go, whereas the second master cone will just go till the coronal third. So it's very important that first you obturate the main canal, which is more easily passively going inside, obturate it, seal it, and only then go ahead with the second canal. So please do not simultaneously obturate in such kind of cases. So coming to your mandibular anteriors, so the incidence varies from 11 to 68%. For your lower anterior incisors, that is your central incisor and your lateral incisor, whereas for your canine it is 18%. So there are various studies which have been done by authors like Vertusi et al. And Gordon et al. Who have said that the most common type of internal anatomy seen is type 1, type 2 and type 3 Vertusi. Now this is what I told in my previous slide, that it is very important to remove the lingual shoulder. When you do not remove this lingual shoulder, this canal you're going to miss. And this is the reason, the most common reason for failures in your lower anteriors, which I have at least come across. So this is very important. You need to consider this when you do the access cavity preparation, only in the buccolingual direction, not mesiodistally. So this is just to show that this is a single canal. If you see here, there are two canals. Again, if you see, there is a periapical radiolucency. To see the 3 months follow-up, how this has been reduced. It has been enormously reduced. So this is very important. When you miss this, then it becomes very difficult for the lesion to heal. It will never heal. So it's very important that you respect the internal anatomy. Now, this is another case of your mandibular canine. So the patient came with severe pain. When I took an X-ray, there was a huge periapical lesion. And then when I actually, started exploring and searching for extra canal, yes, I did get. And this was the reason why the root canal had failed. So this is the post-obturation X-ray. And again, this is the mandibular canine with two canals. Again, if you see the preoperative X-ray, you can see here two faint, very thin lines which are joining and going into one. So again, this is a mandibular canine with two canals. So coming to your maxillary premolars, the incidence of 3 canals is 25%. There are various studies show the presence of this 3 canals. The common type of internal anatomy seen is type 1, type 2 and type 3. And according to Washington study, he said that maximum amount of failure is seen in the premolars. Believe me, I feel if you get certain like complex anatomy, especially in your premolars, it's very challenging. And one of the reasons, you know, why there is, you know, failures in premolars is because of the complex anatomy. So I just wanted to make everybody understand the certain changes, the root canal changes which are seen in the premolars. If you see in class 1, there is 1 canal, separate canal, 2 canal, 3 canals. So there can be 2 buccal canals and 1 palatal canal, or they can be 2 palatal canals and 1 buccal canal, okay? And this is called as class 1. In class 2, there are 2 separate canals. This is your palatal canal, this is your buccal canal, okay? So this has a Y-shaped canal configuration. And again, the class 3, again, it has 2 roots. This is 1 palatal canal, and these are 2 buccal canals, okay, with type 4. So with type 4, what you see is the configuration, which means that it has it originates from the canal orifice and it goes and runs till the root apex. Same goes with the second canal. And class 4 is, it has 1 palatal canal and then again 2 buccal canals in 1 buccal root. So it is the inverse of Y-shaped canal configuration. The class 5 is nothing but 1 single root with 3 different canals. So talking about the access cavity preparation for this, so what happens, like if you see in the previous slide, it had shown that mostly there are 2 buccal canals. There is only 1 palatal canal. So normally the access preparation is in the buccolingual direction. So here there should be slight modification. So the axis should mimic the maxillary first molar, slightly triangular or a T-shaped. So when I say T-shaped, so the vertical line should be in the mesiodistal direction and the vertical line should be towards the palate. So what you need to do is you need to extend mesiodistally, slightly mesiodistally, so that you're able to differentiate the 2 canals on the buccal aspect. So these are the 2 normal canals, which is the normal internal anatomy in your premolars. And these are the 2 buccal canals and 1 palatal canal. And this is a huge 1 buccal canal and 1 palatal. So in a huge buccal canal, there can be 2 canal orifices which are very close to each other. So when you do an access cavity preparation, please use smaller round burrs, okay, especially for your premolars, because the distance is the distance from the roof till the, you know, the furcation area is just 1 millimeter. So if you use longer burrs, there is a large chance that you can perforate the furcation area. So this is very important. You need to keep in mind when you do access for your premolars. So how you go about the endodontic management? So now if you have a normal canal anatomy, you can do with 26% or 25-6% depending upon the canal, and then you know, obturate with 26% GP or 25-6% GP. But if there is, you know, bifurcation towards the middle or the apical third, then it changes, your obturation changes. So now if you can see in this first diagram, you can see that there is apical bifurcation. Okay, this is the instrumented area with apical bifurcation. What you need to do is you need to take, say if you have done the biomechanical preparation with 26%, please take the 26% GP. Just check whether there is adequate tuck back. Once there is a tuck back, cut 0.5 millimeter of your GP and then insert the GP. Okay, insert the GP here. And then what you're going to do is there is a procedure called as down packing. Now what you do in down packing is you fill that 5 millimeters of your apex. Okay, so what you do is once you place the GP inside the canal, you have placed the GP here inside the canal. What you do is you take, there is a down packing instrument which is temperature controlled. You need to just switch on the temperature and heat the GP and remove the excess GP from here, from the canal orifice. Okay, once you remove the excess GP from the canal orifice, there are different tips for that. They can be yellow, red and blue tips. So normally for such kind of cases, you can go ahead with the yellow tips. You need to insert the tip into the GP and slowly switch on the temperature for 2 to 3 seconds. So what happens is the GP will, you know, plasticize, and then again keep on going deeper, and then switch off the temperature, okay? And then use the pluggers to condense the GP. So this procedure needs to be done till you fill the apical 5 millimeters, okay? And then the same protocol needs to be followed for your other canal. Fill the apical 5 mm in both the roots, and then you do a backfilling. So there is again an instrument in which you basically place the GP pellets, okay? At a controlled temperature, this GP, it will plasticize. So it's easier for it to, adhere onto the canal walls. So again, what you do is you do a backfilling in this. So this is the normal obturation protocol which needs to be followed when there is a bifurcation and trifurcation. Okay, so this is the normal protocol which you need to do. So what you see is classification of your premolars. So this is like type 1. Type 1 means there is like single canal. If you see here also, there is a single canal. If you see type 2, there are two different canal orifices. This is the Y-shaped canal. Okay, so these two canals will join in your middle third, and again they will, exit into one apical foramen at the apex. So type 3 is one canal which bifurcates in the middle third into two, and then it joins into one. So this is called as type 3. And type 4 is two different canal orifices which, starts from the point and then ends towards the apex. It basically has two different apical foramina. Type 5 is one canal orifice which bifurcates at the apical third into two. And type 6 is two different canal orifices, which bifurcates and crisscrosses each other at the middle third, and again bifurcates into two at the apical third. Type 7 is one canal orifice which bifurcates at the middle third and crisscrosses each other and bifurcates again into two at the apical third. So type 8 is three different canal orifices which has three different apical foramina. So coming to your mandibular premolars. So the three canal incidence varies from 2 to 35%. Again, there are various studies which shows the presence of this, and the most common type of what you see is classification is seen as type 1, type 2 and type 3. So again, the access cavity preparation would be the same even for your mandibular premolars. So you need to slightly extend more buccally. As we know that the premolars, the posteriors are slightly lingually placed. So what happens, it's very important again to remove the lingual shelf. So when you try to file, when you try to place the file on the lingual canal, again the file will go into the buccal canal. Again, you will miss the extra canal. So it's very important that the lingual shoulder should be removed, especially for your lower premolars, so that you do not miss any canals. Now, if you see here, the obturation is done in one canal. Again, the reason in this, wherein they have missed this extra canal, is because the lingual shoulder has not been removed. So this is the reason wherein they have missed the extra canal. So that's why it's very important that you remove the lingual shoulder because of the lingual inclination of your posteriors, your mandibular posteriors. So like I said in the previous, slides, that there is eccentric location of bleeding point. If you see here, that's when you can expect there is one canal here and one canal here. This is under magnification, which is much clearer. So again, when I had got this case, I could see the radiolucency here, but again at the middle third, I could not see any canal. So first what I thought, because this patient was 75 plus, so I thought might be it's the calcification in this. So I started, and then I started placing the file inside. I could feel something very hard, some very hard obstruction. I thought might be it is calcified. Then again I tried, again I was unable to do it. Then I realized might be I need to extend the axis. What I did is I extended buccolingually the axis more. So once I extended more, what I did is I took a NITI file, I pre-curved it. I took a stainless steel file, I pre-curved it. I took a 8 size K file. I pre-curved and I placed one file touching the buccal wall. And then what I did, I took another 8 size K file, I again pre-curved it, and I placed it into the lingual wall. I placed the file into the lingual canal, touching the lingual wall. Then I could feel that there are two canals. When I took a radiograph, I was like surprised. Again, so these are the two canals seen in your mandibular premolar. Again, if you see here, the radiolucency here, which is very adequate, here you can see a proper bifurcation. So again, this is the post-obturation X-ray. Yeah, this picture I had put up to show the apical bifurcation. See in this, there is an apical bifurcation here. So this is how you need to go about the obturation. First, you need to do the downpacking for the apical 5 millimeters in both the, bifurcated roots. And then you need to do the backfilling here. The backfilling needs to be done here. So this is how we go about in a cases like this. So coming to your maxillary first molars, the presence of MB2 canal has immensely increased. The incidence is very high. It ranges even up to 94% of the cases if you see the literature. It's very important when you're treating your upper maxillary first molar, always believe that yes, there is MB2. And also the bilateral existence has also been shown in the literature if there is presence of MB2 in your 1/6. If you have to go ahead with the root canal treatment for your 2/6, always remember that 100% there is going to be, MB2 even in 2/6. So there is a literature which states the presence of, MB2 even in the contralateral tooth. So this is how the axis cavity preparation looks like, the triangular axis preparation. If you see for MB2s like to say where they're exactly present. So if you see the case reports, there is a varied variation of MB2, presence of MB2. In this line, it can be present anywhere, believe me. There is a lot of changes in the position of the MB2. So normally they say that it is present slightly mesial to a line which is drawn from the palatal to the mesiobuccal, normally present 1 to 2 millimeters. If you see in this, it is slightly present palatal. It is slightly present palatal and at an angle, at an obtuse angle to MB1. So how do you locate this? Now, how you're going to locate this MB2 canals? See, what you need to do is, firstly, there should be adequate axis cavity preparation. When I say adequate, they should be straight line axis cavity preparation. That's very important. And you need to follow the dentinal map. When I say dentinal map, you need to take a probe or a DG16 probe or a normal probe. You need to run it across from MB1 to the palatal. You need to run it across and see whether you get any catch. If you get catch, means that they can be MB2. They can be presence of MB2. That's one method to identify your MB2 canals. The next method, what you can do is you can use troughing with the help of the ultrasonic tips. So there are many ultrasonic tips in the market, which are basically diamond coated. Now, again, you need to follow the dentinal map for this, and you need to trough it from MB1 to palatal aspect. You need to keep troughing. So what troughing does is, it will try to remove the dentine which is overlying the canal orifice, so that it becomes more easier for you to identify or locate the MB2 canal. This is one method. And the next method is, what you can do is, you can place sodium hypochlorite, few drops of sodium hypochlorite into the pulp chamber. Now, what this sodium hypochlorite will do is, it will react with the pulp tissue and release oxygen, nascent oxygen. Now, this oxygen, it comes in the form of bubbles. Okay, so this bubbles, can show that yes, there can be an extra canal. So this is called as the champagne bubble test. This can be done in detecting of any extra canals, like not only for your maxillary first molars, you can use for any tooth. So this is another method to identify your MB2. Now coming to the instrumentation and obturation. So whenever you get any extra canal, every clinician needs to keep one thing in mind is the canal is going to be very narrow. So first you're going to start with 8 size, again 10 size and 15 size. So when you're starting 8 size, it should be super loose inside the canal. Only then you're going to introduce the 10K size file. Once you make the 10K size file super loose, what you're going to do is you're going to recapitulate with 8K file. Then again, you're going to use 15K size file and again super loose inside the canal, then recapitulate again with 8, 10 and 15. So it's very important to achieve a glide path. Spend more time in hand instrumentation before introducing any rotary file inside the root canal, especially for your extra canals. Otherwise, your rotary file is going to separate. So this is very important. And you need to irrigate it thoroughly. Irrigation is very, very essential. Very essential after the biomechanical preparation. In fact, you need to put some amount of hypochlorite so that, during the biomechanical preparation also, there is the hypochlorite chloride is intact, so that, it's easy for the passive passage of your instruments. And also post biomechanical preparation also, the irrigation needs to be done very thoroughly. And then the obturation is normal. You can go ahead with the single cone technique with 20 or 25-6% depending upon the case. Now, this is a 3-canal variation. Again, this is a 3-canal variation. The literature states even the presence of 2 canals. So this is the 2-canal variation which I had done. And again, so this is the MB1 and the MB2, 4 canals. Again, MB1, MB2, MB1, MB2, MB1, MB2. If you see in the distal, there is a 90-degree acute apical curvature. Again, MB1, MB2. Now, this is the distal curvature which is seen in the distobuccal, gradual distal curvature. These are the 5 canals. You have the MB1, MB2, then you have palatal 1 and palatal 2. So that's about the maxillary first molar. The maxillary second molar. So normally there is presence of 3 roots, but definitely there is incidence of MB2 in enormous amount of cases. And also there is presence of bilateral symmetry. So the axis cavity preparation, like how I had told, you're going to follow the same axis cavity preparation, and the instrumentation protocol is going to be the same, and the obturation as well. So if you see in this first case, there is a separated instrument which I had bypassed and obturated. Again, 3 canals, 3 canals, 3 canals. Now, this is the extra palatal root which I got. So 2 palatal roots, and again mesiobuccal, distobuccal. This is MB1 and MB2 in your upper 7. Again, they can be 2 canals in your upper 7. They can be 1 huge bulbous canal. If you get this, most lucky. And coming to your mandibular first molars, always remember in the mandibular first molars, there are always 4 canals. Very rarely you're going to get 3 canals. Very rarely. So if you see, these are the 3 separate canals. If you see 4 canals here, I would like to mention one thing. Normally, I've seen in most of the cases that, the internal anatomy is being changed. Normally, in the distal canal, there is a slight apical curvature, 2 to 3 millimeter curvature is present. I've seen in most of the re-root canal cases that the GP is obturated in this manner. No, that is called zipping. You have zipped the canal. It's very important. As don't like clinician think that, okay, distal canal means 1 huge canal, easy to do biomechanical preparation. So introduce 15 size or 20 size K file. No, always use a 10 size K file. Please understand the internal anatomy, especially at the apical third. Please understand that. That's very important. So this is how there is a slight 2 to 3 millimeter distal curvature. If you see in this case, there is severe canal curvature in your distal root. Again, there is moderate canal curvature in this and slight canal curvature in your distal root. Now, coming to your middle mesial canal. So one of the reasons for the root canal failure is missing of the middle mesial canal. So the normal incidence is up to 53%, and Carlson and Moore et al., what he did, he gave something called as extra canal phenomenon. Now, what is this? What he says that there is deposition of secondary dentine, which has led to the formation of this extra canal. So there are different classification for this middle mesial canal. There is something called as fin, then you have confluent, and then you have independent. Fin means the moment you introduce the file inside the middle mesial, it easily passes. Then confluent means the middle mesial will be fused either to the mesiobuccal or distobuccal. That is called confluent. Then independent means the middle mesial will not fuse either to the middle mesiobuccal nor to the distobuccal. I will just show you in this picture. So you can see that these are independent canals. If you can see in this, sorry, these are independent canals. The middle mesial canal is independent. If you see the fin, the mesiobuccal, the middle mesial, and the mesiolingual, these are fused and finally going into one. So these are called as fins. And if you see confluent, this is one of the most common variation of the middle mesial. Most of the cases, they'll be fused to your mesiobuccal. If you see here in my first radiograph, mesiobuccal, it is fused to mesiobuccal. Again, it is fused to mesiobuccal. Again, it is fused to mesiobuccal. But there is no isthmus. So there are two types in confluent. One is with isthmus and one without isthmus. So this is the middle mesial canal. Always remember, in middle mesial canal, the diameter is 0.16 to 0.119 millimeters, which is literally 2 times or 3 times lesser than the normal diameter of your mesiobuccal or mesiolingual, which is approximately 0.50. So you need to, the moment you're going to introduce the file inside the canal, it is going to be very, very, very stiff. So you have to do adequate biomechanical preparation with your hand files and achieve adequate glide path. That is very important, and only then introduce your rotary files. Now coming to your Radix endomolaris, the percentage of incidence is 5 to 10%, and normally these are present in the buccolingual plane of your distobuccal root. So this is your Radix endomolaris, buccolingual plane of your distobuccal root. These are the few cases of your the Radix which I had done. Yeah, so this radiograph I had put up because I wanted to show the apical, acute apical curvature in one distal root. When I started this case, we know that the patients have a very different set of mind, and there are different type of patients who come to our clinics. So this patient was 70 plus, and when I took the X-ray and I saw, I told, sorry sir, it's very difficult to save this tooth. It has a very bad prognosis. It's better you go with an extraction. He told me, I have all the 32 teeth intact. I do not want an extraction. This is what he told me. And this was one of the most challenging cases I did, because there was only one distal canal, which was, if you see, it looks like quite fine. It's easy for the file to go inside. Whereas it was very difficult to locate the other canals for me. I was not able to locate. Then slowly I started troughing. I was very careful, because if you see here, the remaining dentine towards the focal area is very less. So I was very careful when I was troughing. I used the CPR tips here. So I started troughing and searching for the canals by using the dentinal map. So I got all the canals, and this, if you see, there is an acute curvature here. If you see in the master cone also, there is an acute curvature here. So again, I started this with 6 size, 8 size, 10 size K file, recapitulation, and I obturated here with only 15.6% GP. So I did the biomechanical preparation till 26% GP, but the 26% was not going. So I obturated with 15.6%. I do not wanted to do overzealous instrumentation, especially when there is acute curvature. So this is a case with 6 canals. So coming to your mandibular second molars, so 80%, most of the cases, they are 3 canals itself. So this is a 3 canal variation. But there is a internal anatomical variation which is very challenging to be done. That is the C-shaped canals. Now these are called C-shaped canals. So coming to the incidence, around 45% cases of your mandibular second molars do have C-shaped canals. I've come across a lot of C-shaped canals, even in my PG and even in my practice. So I have, there is also presence of C-shaped canals in your maxillary second molars, in your mandibular third molars, and in your mandibular premolars, and also few cases in your mandibular first molar as well. So it was first introduced by Cox and Cook. He was the person who introduced the C-shaped canal. As the name suggests, it has a C-shaped cross-section. And there was another author named Manon. What he said that it could be due to the deposition of the secondary dentine. But however, this was not the reason why the C-shaped canal had occurred. This occurred because of the failure of the fusion of the Hertwig's epithelial root sheath onto the buccal or the lingual aspect of your root. So this was the reason for the formation of your C-shaped canal. So how will you identify this on the radiograph? See, normally what happens is there is the two roots, they have a close inclination towards each other. Okay, there is a frank fusion which is seen. And also there are, you know, deep developmental grooves. Like I told in my first slide, deep developmental grooves. So these are called as the occluso-apical grooves, which are present onto the buccal or the lingual aspect of your root. Okay, so if there is recession, again, you can probe and see, and then you can get an idea, okay, this could be like a C-shaped canal for your lower mandibular molars. And also, there'll be a huge distal canal. And the third canal, it's very difficult to find out. Normally, in the X-ray, it becomes very challenging to find whether there is one more third canal or no. So, this is the classification given by Finn et al. So, this is the 3 radiographic representation, which shows in type 1 that there are 2 different canals. The second canal is in close proximity to your first canal. If you see, this root is fused. Okay, but there'll be a thin isthmus. You cannot make out the isthmus in the type 1, and with the help of a radiograph, you cannot see it. In this, you can see 2 distinct canals. If you see that the distal canal is very huge, again, they are fused. If you see in the type 3, there is one independent canal. The second canal is in close proximity to the independent canal, and there is a narrow web which is, you know, separating these 2 canals. Now, if you see the cross section, they normally say it's peninsula-like. Okay, cross section, the floor. It normally appears like this. It can be uninterrupted or interrupted. It can be interrupted with a, you know, thin buccal strip of dentine, or this is on the buccal aspect or on the mesial aspect. Okay, so normally they say that it is also called as semicolon. So it can also have a semicolon appearance as well. So there can be 1 canal, there can be 2 canals, there can be 3 canals, there can be 4 canals. So there is a varied variation in your C-shaped canals. So whenever you get a C-shaped canal, after you identify radiographically, once you do the axis preparation, when you can see a C-shaped canal configuration, how do you place files? What you need to do is you need to first place the file in the mesiobuccal canal, okay? And then followed by that, the distal canal, very easy to be placed because distal canals are very easily, you know, negotiable or, you know, easily identifiable. And then in between the 2 files, the third file you're going to place. If you're not able to see, have a proper axis, then what you need to do is you need to place it in between both the files, okay? And also what happens is sometimes you feel that there is a huge distal canal, the file easily goes. When you try to place the file in the mesiobuccal, you feel that the file is going towards the distal itself. Then you can think, yes, this could be a C-shaped canal. And when you come for the biomechanical preparation, the literature states that maximum amount of biomechanical preparation should be done 36%, not more than that. And since there is presence of developmental grooves, especially the mesiolingual canal, please do not do overzealous preparation. Otherwise, you're going to cause a strip perforation and finally the root is going to fracture. So you need to take care of this, especially in C-shaped canals. And again, one of the most important thing in C-shaped canal which we need to follow is the irrigation protocol. Irrigation is very important because of the presence of isthmus. So the isthmus contains a lot of pulp tissue, debris, etc. So this area needs to be cleaned very efficiently so that there is increase in the success rate. So this is very important. So this is one case of mine which I had done. You see that the root tip is here. Just see how the different internal anatomy is there in this C-shaped canal. And there were 3 canals in this. If you see here, you can see 1 canal which is very evident, 1 more canal. The third canal normally is not seen very clearly under the radiograph. So it had 3 canals in this. Again, it is a C-shaped canal variation. Again, 3 canals here. This was the first C-shaped canal which I had done. So again, these are three canals. Again, it's a C-shaped canal. So this is the working length master cone obturation. If you see here, there is a periapical lesion and interdentally there is some amount of bone loss here. See the 3-month follow-up. The lesion has healed and slight hazy bone is formed in the interdental area. Again, this is a C-shaped canal variation. 3 canals, 3 canals, 2 canals. Now, Radix paramolaris. So the incidence for this in your mandibular second molars is 1 to 3%. It is very rare. So normally these are present mesiobuccally. So Carlson had given a classification for this, type A and type B. One which is present mesiobuccally, or one which is present in the center of the mesial and the buccal root. Okay, sorry, buccal and the lingual root. So this is the Radix paramolaris, mesial, lingual, buccal, distal. So this is the Radix paramolaris. So this is the Radix entomolaris in your mandibular second molar. Again, Radix entomolaris in your mandibular second molar, and Radix paramolaris again in your mandibular second molar. Now, middle mesial canal in your mandibular second molar. So this was a referred case, and I first tried to place the file in the mesiobuccal. I could feel that there is a broken instrument. I took an X-ray and I saw that there is a fractured instrument. So I bypassed this instrument. And then I did the biomechanical preparation for your other canal. And then I placed the master cone. I could feel that the master cone is not going. It's just going till the coronal third. Then I was like, I've done adequate biomechanical preparation. Why the master cone is not going? Then again, I irrigated. Again, I filed it for some time. Again, I placed the GP. The GP was not going. And that's when I realized, okay, might be there is one more canal. And what I did in this case is, I took the probe. I started running it onto the mesial surface. I started running it. And that's when I got a catch there. And that's when I realized, okay, there is an extra canal. So again, it was very difficult to negotiate this canal because the diameter was very, very narrow. Again, I started with 6, 8, and 10, achieved adequate glide path, and then only I started the biomechanical preparation with the rotary files. So this is the post-obturation. So coming to the summary. So the endodontic triad, it contains chemomechanical preparation, then complete obturation of the root canal system. This is the basis for your endodontic therapy. However, the clinician should be well versed with the morphological changes of the root canal system. It's very important because this plays the most important role in the success of your root canal therapy. So the risk of missing any such anatomy is because of the complexity of the root canal system itself. So hence, you need to understand the normal anatomical variation. First, understand the normal anatomy, and only then you can understand the variations. Then, careful interpretation of the angled radiograph, various angulated radiographs, use of 3-dimensional imaging, and then proper access cavity preparation, very essential, and a detailed exploration of the interior of the tooth. This can be done ideally with the help of magnification and followed by adequate cleaning and shaping and obturation, and collectively all together plays a very important role in the endodontic success. So these are my references. Thank you.
Thank you very much, Dr. Qurrath. Do you mind stopping sharing your screen, and we could go into the panel discussions, and if you could turn on your video as well, please. Brilliant. I'll pass it over to Nadeem, who is the moderator, and
Yes,
I'm going to just unmute our panelist, Abid, as well.
Yes, sir.
Just give me one moment, please. Abid bhai, can you start your video as well, please? Brilliant. Right. Nadeem, it's all yours. Forward the questions, please.
Thank you, Dr. Mubarak. Mashallah, Dr. Qurrath, crisp and clear presentation. kudos to all that.
Assalamu alaikum, Nadeem bhai. Can you hear me?
Assalamu alaikum, Abid bhai. Alhamdulillah, crisp and clear, Abid bhai. Welcome aboard.
Okay.
Can we start with the first question? The first question is by Dr. Iftikhar Ahmed. He's an endodontist in Bangalore. His question is, while sodium hypochlorite is in the canal, this is pertaining to your slide, Dr. Qurrath.
Yes, sir.
The lateral incisor, I suppose, this is what I assume.
Okay, sir.
While sodium hypochlorite is in the canal, and if EDTA paste is applied on the file and introduced in the canal, will there be any interaction between them?
Sir, sodium hypochlorite will firstly not remove the inorganic constituents of the biofilm, which is formed during the biomechanical preparation. So we have to use the EDTA gel, not the liquid. If we are using the EDTA liquid, yes, then there is going to be a reaction. But if you are using the EDTA gel, that is very essential to remove the inorganic constituents. So I don't think so, sir. There should be any issue. If we are interchanging, the liquid irrigant, basically, yes, only then there is there is a different color which is formed because of the reaction between the sodium hypochlorite and EDTA. And also why we normally say that sodium hypochlorite and EDTA should not be, like when we are irrigating specifically, after sodium hypochlorite, immediately do not introduce EDTA. Irrigate with saline is because the EDTA will affect onto the release of chlorine ions. So the efficacy of your sodium hypochlorite is reduced. So I don't think so, sir. You can use EDTA gel, not the liquid, sir.
Do you want to add anything, Dr. Abid, on this?
Yes, it was a mind-blowing and mind-storming presentation, I must say. Very good. But I have few points to mention.
Yes, sir.
If she will agree, usually she doesn't agree with me.
No, sir.
See, you said to obturate this premolar one by one, right?
Abid bhai, can we come to the question? Can we complete the question first? Do you want to add?
Okay.
Yes. Yeah. The question
as
was.
She said, I agree with her. It's completely perfect.
Right. Can we take the questions and come back to your query, what you had, Abid bhai? Can we take a few more questions?
Okay.
Sir, 1 minute, sir.
Ready for it?
Yes, sir.
Yeah. The next question is by our esteemed endodontist, Dr. Ali Rauthar.
Yes,
he asks, how important is coronal flare prior to introduction of your hand files, especially in obliterate or narrow canals?
Very, very important, sir. There should be coronal enlargement done before starting any biomechanical preparation because firstly, there should be a proper straight line axis. After that, there should be a proper straight line axis when you're introducing the file. So coronal enlargement is very important, sir. If we do not do the coronal enlargement, then there are chances that it can slightly deviate. If there is a curvature, it can deviate from the canal curvature. So this is very essential, sir. Definitely coronal flaring has to be done.
Right. Dr. Abid, you have done a lot of cases with obliterate and narrow canals. What is your take on the coronal flare in these kind of cases?
See, the narrow canals, you have to usually introduce a small size file first, then up to the full length. Then, as she said, coronal flaring is very important, especially in these cases when you have MB2. See, this MB2 has actually an acute angle, so you have to negotiate it. If you slightly do 1 to 3 millimeters about this coronal flaring, definitely your irrigation will enter and you can negotiate it up to the full length. You have to do this, especially nowadays we are doing crown down preparation, so coronal flare is a must.
Right. The next question is by Dr. Iftikhar. He asks, I think this is pertaining to your premolar case, and I think Dr. Abid Bhai wanted to tell something on this. I think both of you can opine simultaneously here.
Yes,
a little more elaboration on downfilling in the bifurcation cases.
Down packing, sir.
Yeah.
See, normally what we do is we do say biomechanical preparation with 26%. We need to use a 26% GP. cut it a bit, 0.5 millimeters. Normally we cut 0.5 millimeters and then introduce the GP inside the canal. After introducing, there is a down packing instrument, which is temperature controlled. So we get enormous different types of down packing instruments. So what we need to do is we need to switch on the heat. There is a temperature variations in that, 150, 110, 200, like that. So you can just switch on the switch and then heat. There are different tips, like down packing tips. You get yellow, red, and blue, depending upon the type of your canal biomechanical preparation you have done, and also depends on the tooth which you are treating. Normally for premolars, you can go ahead with a yellow tip. Then switch on the control, heat the tip. What you need to do is you need to cut off the GP at the canal orifice, first step. After you get cut off, then insert that heated tip inside the GP, the master cone. Slowly insert it for 2 to 3 seconds. Then switch off the temperature, and then put some apical pressure so that it prevents the shrinkage of your GP. And then use a hand plugger. So you need to, there are different sizes for hand pluggers. Again, depending upon your length and also depending upon the canal. So what you need to do is, again, you take a hand plugger and you need to condense it, okay? Once you condense, then you're going to start from the coronal third. The same manner it needs to follow. So coronal third, and then a middle third, and then finally 5 millimeters of your apical third. So you need to take X-ray. You need to take a radiograph to confirm that, you know, apical 5 mm is being obturated. Once that is obturated, the apical 5 mm, then you need to do backfilling. So there are various backfilling instruments, like you get the gun, and now you have the recent advancements in that. You have basically a handheld as well, apart from the gun type. So again, it has a very thin needles, which can easily go inside the canal. And there is a bending tool as well, sir, so that, you know, if you feel that there is any curvature, you can bend it as well. So what you need to do is, there is a cartridge in which you need to put the GP pellets. Again, there is, again, it is temperature controlled. And then you need to heat at that particular temperature. There are different manufacturers which give different temperatures for different devices, sir. Then again, you need to, you need to heat the GP. And once it is heated, what you need to do is you need to introduce till wherever the apical 5 mm where you have obturated, just 1 millimeter about that, just introduce it. And if you have a gun, press the gun, slowly the GP, the plasticized GP is going to, you know, slowly start backfilling, so that eventually the tip will come out, sir. So
Sorry,
that's how
I'm sorry,
Yeah,
I have to interrupt here if you don't mind.
yes, sir.
I think, you know, when you use these wearing warm vertical systems, the tips you're talking about, the
Yes,
yellow,
sir.
red, green,
Yes,
they all have variable taper and a different diameter at the tip.
Yes,
So
sir.
you have to do a little bit of mathematics here. With mathematics, in the sense you do know the working length, and you place your GP, you know exactly where your heat tip is. You have to you have a rubber stopper. You have to measure that length and see to it that the tip actually goes to that 5
Yes,
millimeter from the apex.
Yes.
So clinically, when you're using it, you need to do a little bit of mathematics there.
Yes, sir.
Once you use the right tip, like if your flare is 0.6, I prefer to use a slightly thicker 0.8 taper, because that would actually stop at 0.5 millimeter, 5 millimeters from the apex.
Yes,
Yeah.
sir. Yes.
So you have 8 taper or 10 taper. So
Yes, sir.
basically, this is a lot of mathematics involved in this.
Yes,
In
sir.
simple terms, whichever warm vertical kit you buy, try to use it first on extracted teeth. By a chemical-mechanical preparation, do the obturation, then you'll get the hang of it.
True, sir.
Because most of these kits come with different kind of temperature settings and different kind of GPs. Some come in cartridges, some come in capsules. Capsules are actually messy, but cartridges are better. These do not actually vary the taper of those tips. The tips would be uniform taper, like 10, 08, 12, 04, those kind of tapers. So I think a little bit of mathematics is required. I would appreciate, Dr. Sharief, if you can, if possible, do a live video and then post it on our group when you do an operation, and so the people understand it a lot better.
Yes, sir. Surely, sir. Surely.
Well, I'm really sorry to interrupt your
No problem, sir.
question, but thank you.
So like how Ali sir said, like we have to do the mathematics. In fact, even when we use the hand condensers, we need to first, like how sir said, we need to first know the working length, and the first condenser should be used only like 5 millimeters below the coronal third and again towards the middle third. So that's how it goes about, sir. So first we should know the working length and first know the kind of hand spider you're going to use and then start, sir. So yeah, what sir said is very important, that is. I can't hear you.
Yeah, sorry, I had unmuted myself. The next question is from, I'm going to pick randomly the questions. I think that would be easy for the speaker as well as the panel member to answer. The next question is by Dr. Musharraf Unisa. She asks, what's the difference between Radix paramolaris and Radix entomolaris? Dr. Abid Bhai, can you please answer this?
Radix entomolaris, yes, it's an extra root on the
difference between
distal
paramolar
root. And the paramolar will be on the mesial side, actually, on the mesial root, and this will be on the distal lingual root, the entomolaris. This will be on distal lingual root. And usually these radix roots are smaller than the other root.
Can you shed some more light on this? How do you identify them on X-rays?
X-rays, yes, you can see on the X-ray, you can see a shadow. And when you open it up, later you can see the inside the chamber of the canal, you can make out an extra orifice. That's it. Because usually what we say, it's the internal anatomy which will help you, okay? So it's on the distal, when you have a big distal orifice on the left side, all the distal side of the main canal, it will be there. So it's quite obvious. You can make it provided you have a good access opening.
Do you want to add anything to this, Dr. Qurrath?
Sir, basically, the difference between Radix entomolaris and paramolaris is that we have the extra root which is present onto the extra root for the Radix onto the distal aspect, whereas paramolaris, it's on the mesial aspect. So what happens is sometimes what I felt is it's slightly confusing when you do the axis opening. Normally there are 4 canals in your lower 6. So when there is a radix, it's very important that the preoperative X-ray is very important, essential. Wherein, you know, when you take a mesial and distal angulation, that's when you actually know, sir. Because normally in lower 6, there are 4 canals itself. Very rarely you get 3 canals. So it is 4 canals itself. It's just that it is the extra root. So in such cases, I feel X-ray is very important. So even when we are taking a normal working length X-rays, it's better to give a proper mesial and distal inclination so that, you know, we have a clear picture. Otherwise, what happens is in preoperative radiography, if we have a straight angulation X-ray, sometimes we won't be able to understand, okay, there is a radix. So when we are doing like the procedure, both the working as well as the master cone, give a mesial and distal angulation so that we get a better picture, sir. That's when I feel that, you know, we actually come to know. Otherwise, in few cases, it's very evident that it is radix. But in few cases, it's difficult, sir, until and unless you give a proper angulation, I feel.
So in a nutshell, what I understand is it's better to take, you know, angulated X-rays prior you start the treatment to know whether there's an extra root or not, right?
Yes, sir.
Right. The next question is by Dr. Ali. He says, Dr. Qurrath, this question is for you. Yes. How do you identify these anatomical grooves clinically? Any variations in dentine structure?
Sir, clinically, it is very difficult to differentiate, I would say. Like I had told even in my beginning slides that only if there is recession might be, you know, you can probe the area and see. And definitely, sir, it has a lot of changes on the dentine. When I say dentine, like wherever, for example, like say C-shaped canals, if you say that the fusion is on the buccal root, when you're doing the, say for example, lingual root, when you're doing the biomechanical preparation, you should be very careful in the mesiolingual canal, especially near the focal area, because the dentine there, because of these developmental grooves, will be very thin. So when you try to do overzealous preparation, it will cause strip perforation. So it's, in fact, we need to be very careful, especially when there are developmental grooves when we are doing biomechanical preparation. That's what I feel.
Fine. I would request Dr. Ali Mubarak to unmute Dr. Iftikhar. He wanted to ask this question. Can you unmute him, Dr. Ali?
Assalamualaikum, Qurrath.
Walaikum salam, sir.
Yeah, it was a nice presentation.
Thank you, sir.
Yeah, actually, I was not asking you the procedure of down packing.
Okay, sir.
Okay, what I wanted to ask you was, how do you manage the bifurcation? Like, say one is the main canal, you're going to obturate the 5 mm finally by down packing. What about the other lateral canal?
That's
Yes,
what
sir.
I also wanted to point out before. Okay,
Okay,
carry
sir.
on.
I will just tell.
Yeah.
I'll just tell,
Yes.
sir. So what happens is normally when you have such kind of bifurcations, whether it's at the middle or the apical third, what I normally do is, sir, see, there are chances that, you can miss that extra, bifurcation since, they are present towards the middle or the apical third while you're obturating one. What I always do is, even when we're doing the biomechanical preparation, say I've did the biomechanical preparation for buccal root. Okay, so what I do is I place a 15 size K file in the palatal root. I don't take it out, sir. I do the adequate biomechanical preparation, but I make sure that the glide path is achieved in that so that I don't miss the canal. Then I do the BMP for your buccal root. Okay. And then after doing the biomechanical preparation, I use a 20 size K file there. And again, I do the biomechanical preparation for your palatal root. Okay. Once that is done, I place again 20 size K file. Okay. And then I start the irrigation. First, I start for the buccal and palatal. Okay. Once the irrigation is done, when I'm going ahead with the obturation, what I do is first I take the most easy canal, sir, which I feel that it was easy for me to detect it or identify it. What I do is I place the 20K file in the palatal root. I do not take it out. What I do is I first obturate the buccal canal. Once the buccal canal is obturated, then the 20 size K file, which is there in the palatal, I don't remove that. After it is obturated, I clean the area to make sure it is, I can see it properly. And once I clean and remove the excess GP and everything, what I do is slowly passively do little hand filing with the 20K file again. So that, if there is any GP or sealer which is extruded into the adjacent canal, I nicely do BMP and remove it. And then I obturate the second canal. I think in such kind of complex canal anatomy, this is how it needs to be done. So that's what I
Dr. Abid bhai, you are adding something?
Yeah, Nadeem bhai. If I will start this case as she said, maybe I'll mess it up. So, what I do usually, I will obturate both the canals together. Okay. If I obturate one by one, the sealer might come and it might block the other orifice. Okay. And you have a very small space to work in. Very small, don't forget. So what I usually do, I'll obturate both. And here I don't agree with her about the 6% of the GP in the premolars. Never it's going to happen. I never use it. Even though if your preparation is 6%, what you do, better obturate with the 4. Or sometimes maybe with a non-standardized GP. Or even with the 2% if you can manage. Because you have very small space and anatomy is such that you cannot. I don't know. I cannot do it like this, but as maybe she is doing it, but for me, I have done many these premolars and all these, but I never do it like this. So yes, if you have an upper premolar, yes, maybe you can do the palatal first and the other two, but in the lowers or in the other cases, you have narrow space, you cannot.
So
basically,
if I may just add, if you're using your rotary as an O6 taper, you generally wouldn't put an O6 taper GP in because you may not get it right into the area you need it. So I personally would agree with Abid because I usually use a O4 or a standardized GP. So I'm sorry, Qurrath, you can.
Sometimes, Ali bhai, what I use a non-standardized GP because you have very small space.
Non-standardized, sorry. Non-standardized.
So I would just like to add a thing. See, again, use of 6% or 4% varies from case to case. It's not like if there is if I feel that the canals are very close to each other, I would not do a 6% GP, sir. Like if you see the previous slides also, I've written 0.4% taper GP also. So again, it varies from case to case, sir. And also what I have felt is maximum cases, like whether it is 4% or a 6% GP. When the canals are very close to each other, you put the GP, believe me, one GP will go till the root tip, the other will not go, sir. This is what I have felt. Like sir said, might be non-standardized GP, we can go ahead, but 4% and as well the 6% will not go, sir, together if the canals are very close to each other.
Never.
Right.
Abid bhai, you were saying that when you're obturating both the canals in case of bifurcation,
Yes.
you'll do both together, right? So when you're down
Yes.
packing it, you'll be down packing one by one, is it? At the level wise, how do you go about it? Just a little bit of elaboration on
Not
that.
these cases. These cases usually I will do it with a lateral condensation. Okay.
Oh, okay.
Usually I'll do yes. Upper premolar, there is a space. I will do it with the thermoplasticide.
Oh, okay. Okay.
You are very small there. You cannot flow it.
Right.
Okay.
Right.
Sorry, I think Shiraz wanted to add something to Radix. So Shiraz, sorry, I unmuted you. Carry on, please. Shiraz? Sorry, just a moment.
Nice presentation.
Thank you, sir.
I wanted to add, hi Abid, Assalamualaikum. I wanted to add one point about Radix entomolar is here when we open the axis and when we see the internal anatomy, usually in a Radix case the orifice of the Radix will be far more lingually and more it is very far from the canal. So that's how you get a slight hinge that it could be a Radix internal anatomy. Yeah, okay, that is one point which we have to, as a clinician, we have to keep a note on, where the orifice is far. Suppose you have a normal anatomy and you have a distobuccal and a distolingual canal, they are close together. Whereas in a Radix, the orifice is quite far from the distobuccal canal. That is one point you should know. And other thing is, when you insert the file in a distolingual canal, usually if it is a Radix, the file will have a very drastic bend towards the buccal side. Before you open the orifice, the file will actually will be sitting on the buccal wall of the tooth. So that's how you can actually differentiate with the file as well as the location of the orifice. So that's all I wanted to add.
Yes, sir.
Thanks, Dr. Shiraz. The next question is by Dr. Muhammad Abu Bakr. He's an orthodontist. His query is, I would read line by line. I think that would be great, actually. So wonderful cases, absolutely. But how did you manage to do these cases without RD? That's superb. Well, that goes against the dogma of endodontics, isn't it? Your take, please. And the second part is also for cases for the lower anterior with 2 canals, how did you manage to obturate with CLC technique?
First of all, I would like to tell doctor that whatever cases I have done is done without rubber dam, but under high vacuum suction. There is no spittoon in the clinic where I work. There is only suction. So the chance of contamination is 0% because the patient is not spitting in a spittoon, first thing. And whatever cases I have done, there is definitely, I don't think so, might be there 2% failure, sir, but I would not say more than that. Definitely, no matter how many cases you do or how well versed you are, definitely there is some amount of failures as well in life. But I understand rubber dam needs to be used, but coming to the consultation practice in India, it is very difficult to use a rubber dam for the amount of money I get. So yes, surely I will use a rubber dam. I have to use it after the COVID-19. I have no option. I have to use the rubber dam. So that's one thing. So what was the second question, sir?
Yeah, for cases of the lower anteriors, what you showed with 2 canals, how did you manage to obturate with CLC technique?
What is CLC technique, sir?
Cold lateral condensation.
Okay. So the normal protocol, so for cold lateral condensation is you do the biomechanical preparation, say with 26%. I place the 26% GP. And after that, what I do is I use a 20 hand spreader or a 15 hand spreader and see whether there is any gap. If I feel that there is any gap, then I use a 22% GP as well, or sometimes even the 15.2%. And that's how I obturate. Normally in all my cases, I just do not go ahead only with a single cone obturation technique, because if you see the literature, there is a larger, enormous amount of failures only with the single cone technique. So I also use the accessory cones with the whole lateral condensation technique with the spreaders, hand spreaders like 20 or 15, and only then I go ahead.
Dr. Abid bhai, you want to add anything on this?
See, looking at this post-COVID scenario as about this rubber dam, it's a bitter pill. Sir. I'll say it's a bitter pill, and you all have to swallow it. Looking at this scenario, okay? Yes. So no excuse for without rubber dam, no endo.
I know, sir.
And as she said, she perfectly explained this later condensation.
Good. I think post-COVID, I think every dental clinic will be equipped with RD now. I think yes, without sir. RD, even I think for a basic filling also, I think RD would be applied.
Yes, probably, sir. For basic filling also, we have to go with RD itself.
And one more point I would like to, rubber dam plus high vacuum suction, high vacuum evacuator. If you don't have, you cannot work under rubber dam. Okay. Yeah. You have to get it, because usually what we have, that is the motorized suction. That's not going to work.
Right. So probably
if you have a high evacuator, it will evacuate at 2.
The cost of evacuators are close to 90K to 1 lakh, Abid bhai. Hopefully I get one from Saudi, inshallah. Okay, the next question is from Dr. Nadeem. Is it possible to know middle mesial by looking at the IOPs, Dr. Qurrath?
No, sir. It's very difficult, sir. It is very difficult to know the middle mesial with the X-ray. I would say, like maximum cases which I have done, I have with the help of a probe, the DG16 or a normal probe. Like I learned this in my PG life from Dr. Shiraz sir, is that it's very important that first what you get, you do the biomechanical preparation for that first, and then search for extra canals. So this is why I have got extra canals because of Shiraz sir, because he always says that search for extra canals, even in your uppers like MB2 also. So, you know, you can search for it once you have done the biomechanical preparation. So once I do the biomechanical preparation, that's when I start using a probe to run and see whether I get any catch. Or sometimes what happens if we don't do an adequate access cavity preparation, the canal can be even present in the wall of the axis. So it's very important that, you know, we do an adequate access so that we get the canal properly. So I probe it and then see it. So that's how I do it.
Right. I have a query regarding the same.
Yes.
What are the possibilities of seeing a middle mesial if you have a larger mesial root in an angulated X-ray? Is it any possibility? Can you see the faint canal running in the root?
I have never come across, sir.
Right.
So might be we can find.
In young molars, yes, maybe sometimes. I have seen these middle mesial cases I have seen in young molars only.
Yeah, fine. The next question is
not in the old age.
Right. The next question is by Dr. Ramiz. He asks, how important is magnification? Will it be a good clinical investment in endo per se?
Yes, magnification is like the best if you are doing the endodontic treatment, because might be I'm just probing and getting the extra canal. I'm feeling the catch and getting the extra canal. But if you have magnification, it's very easy. You can see everything. Like when you're using a microscope or if you're using a loop, it's very easy to identify the extra canal. So it becomes very simpler, sir, rather than taking 2, 3, 4, how many ever x-rays just to make sure whether there is extra canal or something like that. It becomes more easier, sir. I feel definitely it's a very good investment on magnification, especially when we are doing endodontics.
Dr. Abid bhai?
Very simple. If you can see it, you can treat it. Okay.
Excellent.
Simple.
Yeah,
Right?
exactly.
But I'll say not everybody can afford. No, if you can, if you have a roaring practice and you are passionate about endodontics, certainly you should invest. At least if on loops, not I will not say microscope loops you can invest.
Probably I can just add a little bit on this. If we talk about magnification, we can just split it into two now. A basic magnification would be your normal loops, starting from 2.5x to 3.5x for a beginner. That is quite adequate till he gets used to it. Probably, you know, once you're used to that kind of magnification, you can always jump to a higher magnification to, you know, 4.3. Then regarding the microscopes, as Dr. Abid said, it is quite an investment, but that kind of investment is always going to serve you, you know, for better doing endodontics in coming time. It saves your neck and your back with, you know, 100 problems. I think magnification is boon in dentistry. Fine. The next question is, I think both the questions are interrelated. One is by Dr. Shiraz Pasha and other is by Dr. Salman Siddiq. What is non-standardized GP? Can you add a little bit more on this, Dr. Abid Bhai?
Non-standardized GP is, it's not marked, it's not color-coded GP. Okay, it's not a color-coded GP.
Okay. Next question, a very interesting question is, this is by Dr. Zahir. He's an orthodontist practicing in King Fahad University. His question is, what is the protocol or recommendation to carry out orthodontic treatment on a tooth which develops external or internal root resorption? And what is the long-term prognosis of each, particularly anterior teeth?
So
You
whenever...
want me to repeat the question or you got the
No,
question?
sir, I got the question.
Yeah.
I got the question. So whenever there is external resorption or internal resorption means osteoclastic activity. So it's prime important that the osteoclastic activity should be stopped. For that, the endodontic therapy definitely needs to be done. Here, at least 2 or 3 sittings with calcium hydroxide dressing so that it differentiates the osteoclast into odontoblasts. One thing. Firstly, different like resorption is normally seen in orthodontic treatment when there is excessive force applied during the tightening of the wires. So I would say that if the tooth is already undergoing resorption, both internal and external, I don't think so the orthodontic procedure should be carried out, because it's very important the osteoclastic activity needs to be stopped first. If it is not stopped, then when you carry out the orthodontic procedure, the tooth is going to fail. Whatever, the tooth is going to completely resorb. They're absolutely going to be nothing. So it's very important that the root canal needs to be done first. Once the root canal is treated, the treatment is done, then you need to recall the patient, say on a 3-month, 6 months, 8 months, 1 year. You need to evaluate how is the resorption, whether there is cessation of resorption or especially the external resorption. And once you feel that there is hazy bone formation, even in the initial stages, the bone which is formed will be very porous, sir. So I don't think so. Even after a year, you can go ahead with the orthodontic treatment. Even if there is, say, for example, there is adequate bone formation, like the hazy appearance of the bone is there. I don't think so. Even 1 year, you can go ahead. Might be two years. Once the density of the bone, the texture of the bone is hardened, only then you can go ahead with the orthodontic treatment. Otherwise, even the endodontically treated tooth is going to fail if you do it immediately after 1 year. That's my inputs on this.
I think Zahir has one more query. Can you unmute Dr. Zahir, Dr. Mubarak? Yes, Dr. Zahir.
Assalamualaikum to all the panelists, mashallah. It's been really great session. So one question regarding the same topic, which I experienced with my patient. We had an external resorption on the upper anterior, and when I consulted the endodontist, he said he's not going to do the endodontic treatment, and what he recommended was a new thing which is coming up is to extract and reimplant the tooth, and that is one of the ways where you can stop the resorption. Otherwise, it's very difficult to do. So what is your take on that one, to like reimplant the tooth?
No, sir, I don't think so. External resorption occurs only because of the osteoclasts. If the etiology is not treated, even if you're going to reimplant, what is going to, change? Nothing is going to change. And reimplantation, I don't think so. In such kind of cases, reimplantation should be done. This is not one of the, indication of reimplantation. No, sir, I don't think so. Because the etiology needs to be treated first. This is not, and also this is not the indication for reimplantation, sir. So if the etiology is not treated, then even if you reimplant also, again, you're going to come back with the same problem. And also, even if you're planning to reimplant, you cannot touch the root surface. For example, if they say that, he's going to, clean the root surface, no. Again, the PDL attachment won't be there. The tooth is not going to be there in the socket. So it's very important. You cannot touch the root surface with any instrument. So I don't think so. So that's a good idea.
So in this case, if we carry out, if we recommend the endodontic treatment to the patient, and the patient is a very young patient, she's just 13 years now. So in terms of long-term prognosis, should we warn that she's more likely to lose the tooth in future and she might need an implant or something?
No, sir. Yeah.
Sorry to interrupt. Dr. Zahir, can you be a little slow when you're asking your question, because I'm feeling it difficult to follow your question. Can you just repeat your question for the benefit of the group again?
Because the patient what I have is she's a 13-year-old patient, and my question is, what do we warn the patient, like in terms of long-term prognosis? Do we warn her that she is going to lose the tooth in near future and she might need to have a prosthetic replacement like an implant? Or what is like how prognosis, what can we give the patient?
So whenever such kind of patients come and you feel that the prognosis is poor, it's very important. Do not tell the patient initially your tooth is going to last. After doing the root canal also your tooth is going to last. Because if anything goes wrong, then we have to be answerable to patient. So it's very important that you understand, make the patient understand this is how the treatment needs to be done. And most probably in most of the cases, there is a good success rate, but in few cases also there is a bad prognosis. So we cannot give like 100% that if we do this procedure, it's gonna be perfectly fine. So we are trying our best. So endodontic therapy, yes, that is the first option for this. That is the first treatment line for this, because definitely what you explained to me, there is a resorption. If there is a resorption, you need to stop the resorption. How we'll stop the resorption is by stopping the osteoclastic cavity. How you're going to do it? Go ahead with the intracanal dressing with calcium hydroxide so that it inhibits the osteoclastic activity. And this needs to be done till you feel that the patient is asymptomatic. There is no pain, no issue. And then obturate, but don't immediately jump into orthodontic treatment. If you're jumping into the orthodontic treatment, the tooth is not going to survive. You should have a proper recall visit. 3 months, 6 months, 8 months, 1 year. When you feel that it's becoming better, if you feel that, the resorption is reducing radiographically, then you can tell the patient, yeah, after 6 months or 8 months, yes. Then you can say the patient, your tooth is becoming better. Might be we need to leave it for another 6 months. And not immediately, even if the bone is formed, no, sir, it's going to be very porous in the initial stages. So again, you do the orthodontic treatment, again, it's going to cause resorption. So I would say 1 to 1.5 year minimum to leave, and only then do the orthodontic treatment. And if you feel that, with the endodontic treatment, it's becoming better. So reimplantation, no, sir.
I'll keep this conversation forward with Dr. Abid. Dr. Abid, you work in a referral center at your unit there. So I suppose you must be seeing cases based on these, particularly ortho-endo, where resorptions have taken place. Your take on this?
This resorption usually is a transient, Nadeem bhai, okay? But you have to diagnose it whether first it is an internal resorption or the external. You have to treat. That's it. Usually it's a transient resorption.
Because I have a colleague now asking the same question. Dr. Salman Siddiq has a similar question. He says the reimplantation is followed widely in his college where he works. He works in Riyadh college. So he says, this protocol is regularly followed to avoid external resorption and the reimplant. And I think Dr. Qurrath disagrees with this.
So can I interrupt?
Yeah, please do.
In reimplantation in a owl's tooth. Okay, that's a different thing. When you have a traumatic injury, your tooth is avulsed, then you reimplant, it's a different thing. In fact, even if you reimplant in an avulsed tooth, again, there'll be, inflammatory resorption happening again in that. So again, it's a different topic and there is different protocol for that, sir. And normally you do the reimplantation. I'm not against reimplantation. So you can go ahead with the reimplantation. For example, you have a lower proper erupted 8, say the third molar, and the lower 7 is missing. Now, if you feel that the internal anatomy is not difficult, like it is not a C-shaped canal, it's a proper 3-root or a 2-rooted tooth, then what you can do is you can remove that and reimplant in the second molar. So that would be an appropriate indication for your reimplantation, sir. A classic example, I could tell you.
Fine. I do understand, but the discussion here was on a resorbed tooth, whether reimplantation can be done or not. The Dr. Zahir here and Dr. Salman, they say the place where they practice, this is, they are regularly done on regular basis where, these resorbed tooth are reimplanted back after the treatment. And you have any papers or something, Dr. Qurrath, the coming time, probably you can post it on GDP supporting the claim. Yeah, that would be great. Yeah. Dr. Zahir, any other query before?
Yes. Sorry, just on the same topic, just last question, because even I am moderating, of course. Doctor, suppose at the end of the orthodontic treatment, what we are seeing is a lot of patients, for some reason, we end up seeing in lower anterior resorption, upper anterior resorptions up to like 1/3 of the root. So in these cases, I mean, we do debond as soon as we see the more resorption going on. Do you recommend endodontic treatment in all the resorbed roots post-orthodontic treatment, or just monitor and just warn them?
So first you can monitor, sir. Immediately we do not have to start off the endodontic treatment. Like obviously the reason for the resorption could be due to excessive forces, okay, which is applied on the tooth. So what we can do is first we will, like you said, after debonding, just evaluate the patient for a few days and then recall the patient and see. If you feel that it's getting better, then leave it for some more time. So initially jumping into endodontic treatment is not the first line of treatment, sir. First, we need to see whether the patient is asymptomatic after the debonding is done. If you feel that the patient is asymptomatic, leave it for a few more days and see the periapical status, or whether it's internal or external resorption. Normally the external resorption. To see whether the external resorption is radiographically reducing. If you feel it's reducing, leave it for some more time. But again, if you feel that it's continuing, the patient is symptomatic, then we can carry out the sensibility test. Once the sensibility test is done, it shows that yes, it has to go for a root canal therapy. Only then we go ahead with the root canal therapy, sir.
Thank you.
Dr. Salman, are you online?
Yeah, Assalamu alaikum. Yeah, I work for King Saud bin Abdulaziz University for Health Sciences, Riyadh. Well, I being in the diagnostic science department, it becomes mandatory for the students to get an approval from me for any kind of treatment. So when this question started, like reimplantation, because I quite often see a lot of cases of reimplantation, almost in ortho cases. Whenever they feel that there is slight resorption taking place, external resorption taking place, they have this protocol to follow. They debond it, leave it for some time, then reimplant it, and then place it back. And they don't even do any kind of other type of bonding, and they just bond it with the ortho bracket, saying that will stabilize the tooth. So there is no other extra bonding which is done, or like how do we usually do it on a avulsed tooth for ligating or stabilizing the tooth. They try to stabilize it with the ortho bracket itself. So because I have frequently been, like when Dr. Zahir asked this question, it just strikes that we regularly do this process here, but I don't have any scientific evidence to or authenticated but this is a practice which we follow. The basic concept with this is they say that they are trying to produce, or they're trying to regenerate the periodontal ligament. So that is when they try to extract the tooth atraumatically, this complete detachment of the periodontal ligament, and when they're trying to reimplant it again, that will help regenerating. And as Dr. Qurrath told, that the etiology has to be treated. So they have the concept, or they feel that by removing the tooth and putting it back in place will solve the etiological problem or try to help stopping the external resorption. Because I have come across a lot of cases like this, because at least maybe a case a month, or 2 cases a month. It is very, very frequently practiced here.
Sorry, can I interrupt, Dr. Siddiq?
Yes,
you said the reason this is being done is to regenerate the periodontal ligament.
Periodontal ligament. That is what is being told. That is the reason I told I don't have any.
But you said you also see n number of cases a month. Have you seen any of them on follow-ups to see how they work?
Follow-ups, it's basically the radiographs. They show much better, prognosis on that. It's like the resorption is slowed down, or probably it is completely stopped in that. I have seen 1 or 2 cases of follow-up, which possibly, if I get to know, or if I get to have the radiographs, I'll try posting it on the forum.
Because I think what they're trying to utilize is probably the stem cells from the periapical region and the bone. But, the growth factors, again, play an important role here. And I personally think it is still a very early field, very, if I have to put it in a very simple sense, evidence.
I exactly agree with this. I exactly agree with
very
this.
Poor.
But here they have a vague way of approach towards cases. Hope you understand. I mean,
no, I totally understand. But I would appreciate if you have the follow-ups, and if you could take
inshallah, because right now we are in a lockdown. I don't have access to any of the radiographs. Once I get access, probably I'll try to post it, and I would let you know. I mean, what difference or how.
That would be great. That would be great. Thank you, Dr. Siddiq. Thank you.
Hello. Can I add a point here?
Can you unmute Dr. Iftikhar, Dr. Mubarak?
Hello. Can I add a point here?
Yes, please, Dr. Shiraz, please.
Yeah, see, extracting a vital tooth will make it non-vital. We have missed out a very important point here.
That will definitely lead to ankylosis then.
And that's what I wanted to say about ankylosis.
See, and like Dr. Qurrath pointed out, you after debonding, you have to follow up the case with radiographs, and also she missed out on doing vitality. So if the tooth has vital pulp, you don't need to do a root canal. So you do a root canal only when the pulp is dead. You don't do a root canal when there is resorption. Okay, so if the pulp is dead, so the etiology would be the more forces. The etiology for resorption would be more forces. So when the forces go away, like Dr. Abid said, it is a transient phase. So when the forces of orthodontic treatment go away, the resorption will stop. So you have to check the vitality, and if you are going to pull out tooth and then place it back, you are going to have a non-vital tooth here again. So that again will lead to a different problem, I feel.
I just wanted to ask Dr. Salman, what is your take on ankylosis of such reimplanted teeth? Dr. Salman.
Yes, it is very obvious. Once the tooth is reimplanted, 99% of the, not 99, complete cases will go for ankylosis.
So then how will ortho treatment be done for ankylosis?
That is the reason, because that is what I told you. Because the cases have been regularly done on this basis, and I don't have any scientific evidence or any proof of that. But here we do it regularly. It's like, even if we say a mild amount of external resorption is seen, they straight away go for atraumatic extraction and then replace it and then bond it again.
Do you have any follow-ups, Dr. Salman, in your hospital?
That's what I told. Right now I'm in a lockdown. I'm not able to access any of the files. In case if I get, I'll surely put up on the
that would be great. That would be great to see some follow-ups, and so that we can educate ourselves, what's happening with these kind of cases. Moving on to the next question. Can you put a word on dents in dente and cases on how to go about start to finish? This is by Dr. Muhammad Abu Bakr.
So basically, dens in dente or dens invaginatus is basically the invagination of enamel organ. So this usually occurs during the stage of soft tissue development. So there are different classifications for this, like type 1, type 2, type 3. In type 1, the invagination does not go beyond the cemento-enamel junction. So this is a different variation. In type 2, the invagination extends above the CEJ, cemento-enamel junction. In type 3, it extends beyond the cemento-enamel junction, but it is going up to the root, and then it forms a separate apical foramen. So this is dense in dente. So what happens is when we have a case of dense invaginatus like type 1, like normally there'll be 2 canals. Now again, dense in dente with open apex is a different case, and the treatment for this will be different. So when you have a closed apex, you can go ahead with the normal biomechanical preparation and obturation. But if you feel that the apex is open, like a blunderbuss canal, it's better to try to regenerate it until and unless the complete tissue is necrotic, like it's a non-vital tooth. If it's completely non-vital, then you have to go ahead with the, the apical 5 mm has to be, obturated with the MTA or the biodentine and followed by the backfilling. Whereas in type 3, the type 3, normally what anatomy is seen in this is, there can be 2 canals, okay, in one root, and they can be dense in dente. That is the separate root, okay. So when there is 1 canal with 2 roots, you can do like 24% BMP and obturation. And the other canal, you can go ahead with the down packing with MTA. 5 millimeters can be placed with MTA and then followed by the backpacking.
Right. Dr. Abid bhai, you want to add anything on dense and dente?
Voice is breaking. I can't hear properly. Voice is breaking. You can hear me?
Yeah, we can hear you. Can you hear us?
You can hear me?
Yes, we can hear you, Abid bhai.
Yes. For this, as she mentioned very nicely, this is a case which is exactly indicated for the CBCT first. I'll take a CBCT, then proceed. Then you can get a correct anatomy and we will do it nicely. This is where the good indication of CBCT is.
Right. I just wanted to, I have a query, particularly treating dense invaginatus. You have different types of dense invaginatus classification given. It's literally quite difficult to treat. Is it better that we directly, to prevent any hiccups in the coming future, directly do a periapical surgery for the particular case and, and wash our hands off and say, okay, I'm done with it, Dr. Abid bhai?
No, I have done few cases, but not with the periapical surgery, nothing, but to be honest. I have done it, non-surgical cases, I have done, and they came up very nicely. Yes.
Right, right. Dr. Qurrath?
Sir, I feel that when there is dense in dente.
Again, voice is breaking.
Hello. Sir, can you hear me?
Yeah, you're clear. I think there's some issue with Abid's connection. You carry on, Dr. Qurrath.
Okay, sir. So in dense in dente, what I feel is that it's very important. There should be, when we say success of root canal, means there should be adequate coronal and apical seal. When I say coronal and apical seal, the apical 5 millimeters is the area which harbors maximum amount of bacteria. So when you're not giving a proper apical seal and directly go with the periapical surgery, it's not going to, treat the cause. Because first you need to make sure that there is a proper apical seal. Now this apical seal is, especially if the canal is very huge, blunderbuss canal. Okay, if the apex is closed, then it's easier to go ahead with a 6% obturation. But if you feel that the apex is very wide and it's like a blunderbuss, then you have to go with MTA obturation, sir, so that you get a proper coronal seal, apical seal. Once the apical seal is achieved, then you recall the patient and then the coronal seal as well. In such kind of cases, what you can do when you know there is a huge periapical lesion, after the obturation is done, you can place 2 millimeters of GIC. On that, you can go ahead with the composite forming a double seal. So you can go ahead with this. And then what you can do is you can recall the patient after 3 months, again after 3 months, 6 months, 8 months, 1 year for a recall visit and see how is it, whether the patient is asymptomatic, whether there are any symptoms, how are the periapical changes. Once the irrigation protocol as well as the coronal and apical seal is formed, I feel that, sir, there'll be immense success, sir.
Right. Thank you, Dr. Qurrath. I think we have just 2 more questions to go and then we'll call it a day. The next question is again by, mashallah, Dr. Muhammad Abu Bakr. He asks, in a patient with ongoing ortho treatment, if a tooth develops periapical pathology and you happen to do endo treatment for that, when do you give a green signal to start ortho again from your side, that is from the endodontist? When do they advocate to the treatment?
So when we say the periapical pathology, sir, there is different classification. You have periapical indexing. There's something called, and there are different classification for this, depending on the radiographic appearance, basically. So what they say is, in the literature, it is stated that when there is a periapical pathology, first thing, treat. Okay, you go ahead with the root canal treatment. After the root canal treatment is done, evaluate, recall the patient for 3 months. Please keep the main x-ray. The obturation x-ray has to be there with you, so that when you recall the patient during the third month interval, you compare it with that and see how is the rare fraction, the periapical rare fraction, how is the size of it. Do you feel there is decrease in the size? If there is decrease in the size, good enough. Recall the patient again after 6 months and again check with both the first and the third interval radiograph and see how is the periapical rare fraction. If you feel that the periapical rare fraction is reducing, okay, then it's a good sign. Please recall the patient again after 1 year and see, evaluate. Because, sir, few authors say that, you know, in literature that it takes approximately 1 year for the lesion to reduce. But if there is a huge lesion, there are, you know, case reports as well as literature which states that it takes even 5 years for the lesion to heal. So again, it varies from patient to patient and also on the, depending on the size of the periapical rare fraction, sir. So that is one thing, sir, I would say. So it again depends.
So as an endodontist, when would you tell the orthodontist to, you know, start his ortho treatment?
So
You're
when
going to, yeah,
yes,
please.
So sir, when I do a treatment and when I recall the patient, say after 6 months, if I feel that the lesion is reducing, then I say let it be there another for 6 months. Probably after 1 or 1.5 years, sir, not before that.
So you mean to say we have to stop our ortho treatment till the lesion subsides? That is what you're advocating?
Yes, sir. Yes, sir. Very important.
So no active treatment to be done during that stage.
Yes,
Keep
sir,
the
no
patient on the passive treatment, you know, just hold on the ortho treatment till you give a green signal, right?
Yes, sir. Yes, sir.
Fine. Thank you very much. I think the last question is by Dr. Shiraz Pasha. He asks, in non-standardized GP, is it only the color coding which is absent or even the sizes are non-standardized?
Sir, even the sizes are non-standardized.
Sizes are non-standardized.
Not only the colors, sir.
Right. But Dr. Abid, do you really reckon that we should stop using standardized GP and start using non-standardized GP?
Selected cases, not in every case, like where you have a very small space, not in every case. See, sometimes even you are 4% and you don't have a space for the another 4% GP to place. In those cases, sometimes I'll place a 2% GP.
Yeah, fine. Because most of the practitioners, you know, they are confused. They, you know, they correspond to the final taper to the final GP and they try to seal. And that is where
never, no, it's not like that. It's not always like that. It's not always like that.
Most of the people have those hiccups. Fine. Alhamdulillah, a beautiful question answer session. Thank you, Dr. Qurrath, and thank you, Dr. Abid Bhai. Dr. Mubarak, the dice is all yours. Yeah. Thank you very much. Sorry, we have a last question coming up, Dr. Mubarak. Can I take the question with your permission?
Yes, yes, please.
Yeah, the last question is by Dr. Muiz. He's an orthodontist. He says, if the lesion is seen, though the tooth is asymptomatic after RCT, do we need to put a halt to ortho treatment? I repeat the question. I repeat the question. If the lesion is seen, though tooth is asymptomatic after RCT, do we need to put halt to the ortho treatment?
Better.
Can you just elaborate on that?
I feel so when there is a periapical lesion and then you're putting the external forces, I don't think so it's a good thing happening to the tooth. The tooth is already undergoing certain periapical changes and over that you're putting pressure. So I don't think so, sir. It's a good thing to go ahead with the orthodontic treatment if there is a periapical lesion. That's my intake, sir, on that, my input. but there are few people, like I have generally seen, that even if there is a periapical lesion, even the after the root canal is done, like Sir said, if it is asymptomatic, people go ahead with orthodontic treatment.
Yes,
then orthodontic treatment will take ages, no, to complete. Then orthodontic treatment will take ages to complete.
We have Invisalign, sir.
That's a different topic to speak about.
It will take ages.
Time. See, what I understand what I understand is if there is an active lesion which is there, you treat the lesion and you stop the disease to spread and wait for some time and keep your mechanics passive, not in active form, and probably correlate to your x-ray and to see the lesion, whether the lesion is subsiding or not. If your lesion is subsiding, probably then start your orthomechanics with light forces.
Yes,
that
sir.
is what I understand, right?
Yes,
Fine. Thanks a lot, Dr. Qurrath, and thanks a lot, Dr. Abid Bhai. Over to you, Dr. Mubarak. Thank you.
Thank you. Thank you. Thank you.
Thank you very much. It's been a brilliant presentation by Dr. Qurrath, and Abid Bhai, thank you very much for your generosity and making time off from your busy schedule. I would like to conclude by saying that this recording would be available on our YouTube channel, on the GDP YouTube channel. So please, if anybody's missed it, please follow it and please probably have a look. But thank you all and have a lovely Sunday.
Yes.
Inshallah, we will have more meetings later. Jazakallah khair. Thank you. Thank you very much.
Thank you. Thank you. Thank you, Qurrath. Thank you, Ali Bhai.
Thank you, sir.